a really nice break. While we wait for other people to join, I think we can possibly start now because time. So thank you for those that have put in their conversation in the chat box, and that is reassuring to see that people have really having a good grasp of what we're discussing this morning. So it means that what people are doing makes sense, absolutely makes sense. What you guys have done, it absolutely makes sense. And I would probably say we're going to take turns to look at those examples. For the people that have added those examples, I will give you opportunity to speak about them, but you don't have to. Okay? By just sharing it is more than enough. You don't have to share your conversation. I think I will start the first one, which is the PDF document. You can go back to the WhatsApp chat. There is a PDF document. I think it's ratfngboss global links at gmail.com who shared it. So whilst there is no definition of the condition, but that's fine because I didn't ask for it. I just say pick any case. So the person has put in the or maybe let me just share so that we all see what I'm talking about. Let's see, and people can comment on it. So we're looking at the PDF document. Why don't we share the entire window? Screen. Yep, that's it. So this is the first one I'm looking at. So the person has put in weakness as one of the impairment, which is right. That is what we discussed, weakness of one side of the body in stroke survival, so post-stroke. And we said activity, so that is the derangement is weakness or muscles. That's the derangement in body structure and function. So the structure that have been affected in this is the muscles. But it would have been specific. I expect, of course, I know in your services, you will make it very specific, such as the particular weakness of the lower limb or weakness of the particular muscles group. And sometimes you can link the activity limitation directly to the impairment. Others, you have more than one impairment affecting activity limitations or one impairment affecting giving rise to more than one activity limitation. But this one is a straightforward one. We have the difficulty walking. So if the person has weakness of the lower limb, I will imagine, that will translate to difficulty walking. So unable to walk or difficulty walking is fine. Now, participation restriction is the person won't be able to drive their car, and that will limit them from social engagement or driving car. Maybe driving car is one of their hobbies. In terms of ideas, I think the person has put in, which is also brilliant. What can we do to help weakness of the one side of the body? So he mentioned PM. I imagine that's passive movement. So passive movement, talking about PNF, strengthening exercises. So I would go probably for strengthening exercises, and there are different ways you can do it. So that is, if we are targeting a specific muscles, we will be doing part practice of that strengthening component, but we can do a whole practice of strengthening as well. But let's say strengthening for simplicity's sake. The activity limitation of difficulty walking, alongside our strengthening, or once the patient progresses to be able to stand and possible walk, is we can do gait retraining. And there are good examples here using stair climbing or gate ladder. He mentioned about functional rehabilitation, such as pedaling or grips functional retraining. So that's for hand, upper limb dexterity exercise. So this is good. Now, for participation restriction, how we can help the person is talking about goal setting in terms of returning to their driving, but we can suggest about modification of vehicles. Absolutely, yes. So we tend to, there is usually companies that can modify individual vehicle. So if their weakness is one side, they can have the functions that the leg can do. Some vehicles can be modified where the person will be using their hand like a joystick in their hand, and will be sort of using the hand to change. If it is automatic, it just start stop, or use one of their legs for the brakes, and then all they need to do is just leave the brakes and then continue, and possibly invite OT for review. Now, outcome measures that can be applied is the Oxford Muscle Grading Scale, yes, to assess the muscle strength. Now, functional walking, you can use the 6-minute walk test. Yes, you can use the 6-minute walk test, but the 6-minute walk test, my question is, you can be used for endurance, I believe, but also, yes, you can use the 6-minute walk test to assess, to see how far they walked. But mainly the 6-minute walk test is for exertion endurance, but you can use, because I would imagine somebody with walking difficulty, the 6-minute walk test would be a challenge. But yes, you can use it as an outcome measure. Now I think the person is trying to mention Fugamaya functional assessment tool. I think is a good question mark. This might probably sit on the activity section, not on the participation level. So this outcome measure will best sit on the activity section, not on the participation level. Brilliant. That's good. Excellent. Can we, whoever is the person, can we give the person a round of applause? You know the chat function I was talking about, so try to react. Can we clap for the person, please? Let's give the person a round of applause. Use the emoji to give the person a round of applause. Okay? And whoever is the person, do you want to add to everything? Do you have any question on this particular one, or do you want to add anything? Because it's an email, so I don't know the person. If the person is on the call, can unmute themselves and add to that. Okay. Okay. If not, let's move to the next one.
It's me, sir.
Okay, yeah, carry on. Yes. Oh, hello, sir. Mr. Adodoku. Yes, please.
Yes, sir. I don't need to add anything. Thank you for
Okay.
the.
Okay. Thank you
Thank you.
so much for sharing. Well done. So let's move to the next bit. Yes, I think the next one is goodness. So goodness has done a very detailed job. Thank you. So we have a context here. We have a 50-year-old teacher, very specific secondary school teacher with right frozen shoulder. And this is quite an important information. Dominant side. It means so we will start to think about the influence. So these are information. This will start to give us influence of how it affects the functioning of the person's life. So thank you, goodness. So dominant side with complaints of pain and stiffness. Okay, so pain and stiffness. By here, I can start to see my impairment. So pain and stiffness on the right shoulder 5 months ago. So the impairment level we said is pain, which is true. So the pain here from this case, that's good. Even we even have a VAS score. So it's 6 out of 10 at night, and movement. Long range of motion. So external rotation is more compared to abduction compared to flexion, which is characteristics of frozen shoulder. So that's good. So and I guess there is because of the stiffness that the person has lost range of motion, and possibly weakness because there is avoidance. So rotator cuff and scapular stabilizers. So Functionally, how does it affect the person? Now, difficulty reaching overhead. So which is, well, I believe, due to limited range of motion or avoiding because of fear of pain avoidance or weakness, all of them. So the first one that can affect difficulty walking, reaching overhead and behind the back. Now, in this context, you can link this activity limitation to all these three impairments, because all these three impairments can affect the person's ability. So, for example, let's take the first one, pain can make the person to avoid reaching overhead because it will increase their pain, or to put their hands behind their back so they will avoid it. Or we can think of the loss of range of motion because of limited range. The person cannot be able to do this, particularly reaching behind their back as well. Well, flexion, adduction, and external rotation, or going overhead. A muscle weakness, but mainly is pain, and then the rest also the stiffness, then the weakness. So that is one way to look at it. So all these three can affect this. And then the next one is the functional reach deficits. Um, I'm not sure entirely what this means, but I believe I know there is functional reach whereby the person trying to reach outside of their base of support. So probably that's what, and I will invite you if you want to add. So I think that's what the person, goodness, is trying to explain. Functional reach deficit, which is good, and in their day-to-day difficulty lifting and carrying objects. So this also you can link to all these three. So it's not the fact that you are linking one directly to the other. So it's not the fact that pain has to link directly to this. This can affect this, can affect this, can affect this. But as far as the patient is concerned, these are the difficulty that is affecting the person, which are all different, sort of affecting their different parts of life. And then if we move on to the participation level or participation restriction, are unable to cook and wash properly. And without the person explaining, I would imagine that's true, because if you are cooking in the kitchen, especially those of us, those people that have not the modern kitchen where you have the kitchen cabinet, all those things, you have to reach overhead to get the Maggi cubes or the salt, all those things. And even the cooking, even without reaching overhead, you have to carry some objects here and there. So they mentioned difficulty carrying objects. That is terrible. And I would imagine all your conversation here talking about vascular or range of motion working with weakness, it will not make a sense to this person. What will make a sense to this person is I will help you. How can we enable her to be able to cook and wash properly? And when you mention something like that, that is the patient-centered goal, where the patient will see reason to cooperate with you. And this is where the patient is more interested in how will it help me. Um, Reducing ability to write as a teacher or carrying market goods. That is good also. Difficulty carrying market good. How will it help me as a teacher to be able to do those my day-to-day activities? Or it will also make sense to the patient in terms of this or this. So when we are setting goals, and this is a very good example, it is highly encouraged. The goals we communicate or set or pass to the patient is around this. That will be my recommendation. Within the activity limitations and participation restriction, goals that are visible to the patient, goals that your patient can relate with, goals that your patient will be able to uh, practically see the changes in their life. And then what sort of brilliant ideas do we have? So pain, while you will be doing heat therapy, yes, we know that works. TENS, yes. Gentle pendulum exercises, yes, just to give that range of motion. Grade 1, 2 joint mobilization, yes. Scapular mobilization, yes, because that restriction. So because that's good, goodness, because we know that range of motion of the shoulder. So the scapula, there is the a false joint, sort of the scapulothoracic joint. So when you're reaching out for an object, the glenohumeral joint or the shoulder joint can move to a certain degree. And once you have a restriction of your scapula, you will find there is limitation on how much you can reach. So that's good. All those things are brilliant exercises. And then we have muscle strengthening with minimal resistance as tolerated. It's important because of pain. And then these are all the ideas. Now, functionally, wall walking, step ladder exercise, yes, trying to reach up, try to increase the patient range of motion. Gradual functional lifting and reaching training exercises as tolerated, yes. Just so this is good because this is where we talked about function. We said if the patient reduced and the range increased, we need to figure out how we can make it relevant for the patient. And sometimes the exercises, the individual exercises. So imagine if you are doing focusing your rehab ideas at this section, impairment level. Sometimes the patient will be get bored. Well, some patient might get bored if you're just doing exercises. But think of if they can tolerate and you are doing something like this, gradual lifting. Imagine you say they are lifting their day-to-day goods. They will find it very interesting and exciting, and that will motivate them. And then the participation restriction, graded return to their activity program. So are we talking of return to schooling or return to cooking or something like that? Ergonomic advice, yes. Work modifications, absolutely yes. Patient was advised to write on the lower boards, yes. These are all work modification. Now, the interventions here is facilitating the return of the patient. Even while we are still working here, this has not gone all the way, but we don't want the patient to stay and be losing money. We don't want the patient oh, don't do this, sit at home. All those days are gone where we just ask the patient to sit, relax, rest. We have to figure out how we can gradually expose the patient to their day-to-day activities. And that is excellent example here on how that can be done. Outcome measures, we all know our VAS score, goniometer for Apple's scratch test for all those spatial tests of the shoulder, manual muscle testing or Oxford muscle grading scale, they are the same. Shoulder pain and disability index, yes. And I think this one maybe has some component of participation as well. But like I said, it's fine. We don't have to add this bit. So yes, that's another good example. Thank you, Goodness. Do you want to add or expand on this, Goodness?
No, sir. No, thank you, sir.
All right, brilliant. Thank you. And I can see another, thank you. So other people have added that bit. The next one, it's yeah, I think Jennifer has two different forms, but we'll use this one that I've already downloaded. So this one is a 23-year-old man, an undergraduate student, okay? So it's important. These are all information that we are talking about that informs us of the context of the patient. One, he is young. All I'm thinking now is a young person, what can I do to keep him upbeat and engaged? He's a student. It means that there are exams around. So we don't want to, we have to start thinking about how it impacts on his studies. And very unfortunate, he presented with left hemiplegia. He had a stroke, which is sort of uncommon on young people. Secondary to right hemiplegic and complain of not being able to move the left and right hand side. The body derangement is the weakness of the muscles of the left upper limbs and lower limbs. And yes, so that weakness, difficulty with ambulation, yes. So we can see another example here. Whilst this is the impairment, it can fit into all these categories. of the patients, and then the participation, returning to university. Yes, I think that's the most important thing. So this is where you linked the interest of the patient being the undergraduate with what they want to do. Inability, a young person, you cannot imagine how frustrating it is. And at this stage, this is where the frustration comes in. A young person not able to participate in this sort of age-related activities, it will be really frustrating. And this is where, as clinicians, how we manage this in our rehabilitation, how we appreciate it in the patient recovery to support them. And we don't have to wait for them to all be good, fine and good, but we see how we can expose them to those social and sports activities within their function or as tolerated. Emotional stress, so this is where the psychological bits is affecting their participation in academic work. Now, this is excellent, brilliant idea for the rehabilitation. We talked about strengthening depending on the level of recovery from active assisted to active resisted. Talking about all those approaches of rehabilitation. Brilliant, mirror therapy, neuromuscular, all depends on activity level, making it functional. Yes, I like this functional reaching. CIMT, all of them are brilliant examples. Muscle testing, Ashworth, if the person has spasticity. Brilliant. Back balance, exactly. Thank you so much. I think this is also another brilliant example. So I think 3 good examples, and I know Enoch have put in his own as well. Jennifer, do you want to add anything on yours? No? Okay. I think these are 3 examples. I think we have good examples. So this is just going to stop sharing my screen. Going to come back to my PowerPoint. Okay, not since I'm at work. Okay. Okay, in the second one, thank you. So this is what examples that we are talking about of how we can integrate the ICF framework. And these are all excellent examples. I want us to, let's see if I want us to, so I think earlier on, these are what I've done. Earlier on, we looked at this example just to come back to the whole class example so that everybody is on board. We looked at this, and this is what I want us to think. So this is just an example, another example, which I wanted us to use as an example before we go on break. But I can see that you guys have already figured it out. So I will walk through this. So this is somebody who is having difficulty trying to get out of sitting from, well, standing, difficulty standing from sitting position. So the limitation is difficulty in transiting from sit to stand, for example. That's transfers. And you can imagine it will affect their functional independence, mobility, as well as walking. But behind every limitation, we know that there are impairments that are affecting that. So the question is, what are the possible impairments affecting the person's being able to stand up, transfer from sit to stand, or walk or move? And by mere looking at this picture, we can see that there is certainly spasticity. We will assume, unless we test it, but I can see there is spasticity. The way the hand is in the slightly flex position for both the upper and the lower limb. There is muscle weakness, because spasticity can be a weak muscle. So possibly there is muscle weakness. But if I'm looking at transferred from sitting to standing, I will probably talking about the lower limb muscle weakness. There is reduced trunk control or postural instability. There is also asymmetrical weight bearing. The person looking at it, is favoring the non-affected limb, and it's important when somebody is sitting to stand. There is what happens with stroke patients, but we will tell poor planning and coordination, whereby they plan what to do. And all these are underlying impairment that are affecting the patient, and possibly the conditioning due to reduced activity. And if we're thinking of the possible treatment plan here, is to improve the sit to stand performance of this patient. I will think of, we talked about asymmetrical weight bearing. I will think of symmetrical weight bearing in a safe manner. I will think of symmetrical weight bearing. I would think of task specific practice. Example is a repeated sit to stand practice with graded assistance. So I will expose the person gradually, starting from, I can decide to increase the height of the chair, and then the person starts from that height chair and then lower it down, just to work on that. So with this, I'm not only strengthening the muscles, but also I'm translating it to function. So my rehabilitation, if I'm interested in, of course, I can do strength exercises of the quadriceps, the core muscles, the postural muscles. But apart from that, if I'm focusing on activity level interventions, where I will think of sit to stand, graded exposure of sit to stand by manipulating the bed height or the chair height, which will increase the difficulty. I will be encouraging the patient to bear with symmetrical weight bearing when they are doing the sit to stand. And I will also work on the balance and neuromuscular facilitation, the tactile cueing, the mirror. I can put a mirror in front of the patient, and I will ask the patient when they, first of all, to position themselves in a very symmetrical way. So they will look at their posture, and once they are standing, they try to make sure that they balance their weight between the two legs. And if they are in standing position, I will encourage them also to sort of make sure they are putting weight in between. Possibly functional electrical stimulation, possibly. And I can use my environment, all those things. And let's say the patient has fear of falling, because it's a tricky position to be in. Imagine for those that are here last time, his weight, his gravity by this posture, there is displacement of gravity. He has reduced base of support because he's not using the two legs. So it might be that the person is afraid of falling. That's why maybe he's hesitant to just stand up. So I will gradual exposure. I will do some education and confidence building. So my sit to stand will be structured in a way where the patient is supported to translate in a safe manner. So that's what I will do. Now, I want you guys to help me, for especially those that the same activity sheets that I've uploaded. I want you guys to help me with this video. So I'm going to play this video. You tell me what is the impairment, what is the activity limitation possible, and what is the participation restriction possibly, and what are you thinking? Oh, Just to confirm, so that I'm not just playing videos and you cannot see it. Can you all see the video recording that I was sharing?
Yes, we can see it.
Okay. So I will play one more time.
Starts with the mind. Mr. Muhammad Zulhimi.
Yes, I'm the one deliberately replaying it. Okay, somebody say. Yes, I'm the one deliberately replaying it because I want you to just watch the first part of it. That's why I'm sort of replaying the video. So it was deliberate for the replaying of the video. Let me just play it one more. So I've put in the video just in case for those that have not were not able to see it. I'm putting it also on the chat from WhatsApp. So all you need to do is the first 15 seconds. First 15 seconds for the video to get your information. So just watch the first 15 seconds and we're going to talk about what do you think? So the question is, looking at the ICF framework, what do you think are the impairment on this patient? What do you think are the activity restriction and participation? And what will you be doing for this patient? I'm going to play this video just two more times. Okay. What do people think of Muhammad's condition? So just general thoughts. What do people think based on everything we've been talking? Both include using the ICF framework, but also considering the broader conversation about his situation, the depression, the isolation. But first is the ICF framework. What are your ideas basically? So what are the impairment? Let's start from the impairment. Can we put in the chat box? Or you can unmute yourself from the video. What are the impairment?
I think the obvious impairment from the video, we can see paralysis of half a mirror image of the body affecting the left side of the body.
Yes. Yes, thank you.
But I want to ask a question before
Yes.
analyzing again. Was his consent received before this videotaping? Is it legal to videotape a patient to, put it in the media? So, does his consent has to be received before you can do such kind of recording or videotaping?
Absolutely. So I think it's a very important context, especially with clinical documentation and rehabilitation. Um, so the answer is yes. That's the simple answer. And I think they are making a documentary on a research they are doing. But number one is absolutely yes. His consent has to be taken before videotaping. And let's be mindful professionally of using our gadgets to record patients. So that's a very important point, Rabiu. Yes, his consent. I believe that's the basics of what they would must to do before they take his video. And secondly, just while you mentioned, we can use observational analysis whereby we record patients and then look at the kinematics and biokinematics of the movements and then sit down and analyze it, because as clinicians we cannot, sometimes just by looking at it we might not appreciate the full picture, or the patient themselves will not be able to see the progress that they are making. So there are, both in certain organizations they have a device, a gadget like iPad specifically designed for doing recordings of patients, but those devices, they are encrypted, have all the necessary regulatory requirement, and they are not personal device. And the recording only take place when the patient is happy, and the purpose of it is clear to the patient. And they use it, for example, when they record it before the start of an intervention, and they will show to the patient, and it's part of clinical, all these objective markers that we use. And then after a while, they show the patient back again the progress the patient has made. Now, patients are so surprised, and you can see the smiles on their faces when you record them at the start, and then you record them as you progress. And secondly, there are softwares, specific softwares that usually used, especially in sports. They use that a lot. You know, when you're looking at sports analysis, they will draw all those lines. So there are softwares that you can download and use on phones, on tablets, where they will help you make analysis of those heel strike, knee flexion, extension, all those degrees range of movement while the person is doing it. But that's a different, talking about biomechanical analysis or observational gait analysis. Then the last one is in terms of recording. Consent always has to be taken, but the last one is some patients on their own really love to record uh, their progress. Now, some of them record it to see where they have journeyed through, while some of them record it so that they will remember the exercises they will be doing, okay, so that they can play it back in. So you will have different scenarios where you will be recording it, but just to digress a bit in terms of the recording, and the point you raised is valid. So thank you. And I think the Favor has mentioned there is no heel strike. Yes, there is no heel strike. So these are all the impairment. And then they have an activity implication. Either the weakness of the half part of the body or the heel strike, it will translate to some difficulty in the patient's life. Other, it will translate to some difficulty in the patient's life. And I'm just thinking, from the video you're looking at, what do you think are the possible difficulty that the patient will have, activity limitation, from what we just saw, the video, the weakness, the muscle weakness, all those bits? And you can put it in the chat box. So, yep, while people are typing, what I'm saying is that I will imagine the person walking is the obvious one. Okay, difficulty walking. Difficulty with sit to stand transfers. I will imagine the person will have difficulty just sit to stand transfer. Independent standing, because you see he has to be supported in the parallel bar. He's lifting on one side. So there are quite a few things that the person will have. And then participation restriction. I would imagine, and from what he is saying, which leads to the depression, is the isolation. So there is that lack of community engagement and activity. It's a young person, so I will imagine that there is that part of the community engagement. Social roles, return to life, perform ADL, recreational activity possibly. And if we are thinking of rehab ideas, the same thing that you guys have mentioned earlier on, strengthening, if we talked about weakness, if it's at activity level, task specific training. For example, the video is doing a parallel bar practice with this patient. So that's a good way to encourage the person. Get progression. You can progress from the parallel bar to using maybe therapy supports. And one of the main things he mentioned, which I picked, is the depression, the isolation, is the community reintegration. So I will imagine the therapist will be thinking of not working him in the parallel bar or in the wards only, but community reintegration. Maybe thinking of how he can work in the community with or without a device over a period of time, the confidence building. So that's one. So in terms of patient preference, if you're looking at objective assessment, oh, thank you, AE. AE has updated his also template. Patient might report to us that they have difficulty with standing, walking or independently. So if you think of your subjective, now we're starting moving to the template assessment generally. So if you think of your subjective, your patient will come and say they report difficulty with standing or walking independently. They might talk about expressing concerns about balance and fear of falling. And then we will now do the objective assessment in terms of balance, muscle weakness, and all those things. Asymmetrical observation of asymmetrical bits. And in terms of analysis, if you think of the impairment, activity limitation, and participation restriction, analysis, you can say probably the difficulty to sit to stand or difficulty to transfer due to lower limb weakness or due to pro control or combination of all or balance or reduced proprioception. So what is that? And affecting the patient's ability to function in the community. Okay? And your probably short-term goal will be improving the symmetry, improving the muscle strength, and then your long-term goal is for the patients to be able to work within the community with some sticks or frames. And then you design your treatment, the frequency, and things like that. So the ICF framework, why the changes? I think the summary of the conversation so far is why changes at the impairment and activity level are important, but they are more important to the patient, especially activity and participation, but participation more. If the patients can see the improvements if they in their own daily lives. So the improvements are more meaningful to the patients if they translate to real life situations. For example, ability to attend a social event, ability to engage with families, and then you work backwards, ability to return to work. Because when you mention that, the patients and families all of us value functional independence. All of us value social engagement. So it's not just the clinical gains, brilliant. It's not just the clinical gains, but translating those gains into daily practice. And apart from this intervention, the outcome measures, which we've not talked about in detail, but that's not the focus of today, is that the way we measure those change, also measuring the effects of our intervention, we can measure it at different levels. One level is the impairment level, which people have done brilliantly well. The other level is the activity level, and then the other level is the participation level. And it's good we used a standardized measure to measure those changes as professionals, standardized valued measure, and there is a different conversation on outcome measures, which hopefully I will do a training sometimes differently on outcome measures. But outcome measures has to measure what they intend to measure, appropriate for the patient. There are what we call meaningful, clinically important difference, something that the smallest perceived difference change that can be beneficial to the patient. And I see a lot of examples in the examples of case studies that people have put in. And like I said, thank you, because I want, my whole aim is to see that we are all on the same page, which I can see from the examples. The engagement means that people are following the conversation, or people know about it, like I think some people mentioned. So when we are planning our rehabilitation, or when you are going through our assessment, I think the question we should be asking is, will strength or mobility gain help the patient to walk to the shop or to join the family on
Okay.
meals
We have
or to
Kiratin.
return to work?
What makes Villa?
And we document.
Kiratin. What makes Villa?
Hello, I think
Ahmad.
it's some. Let's see. Yeah. So would that help the patient return to work, join the family meals? But it's not our subjective views or the patients. Sometimes as professionals, when we are doing the documentation and when we want to establish the effectiveness of intervention, when we want to show that our work is what we are doing make a difference, is document the progress at every level using a standardized tools that we talked about. There is what we call the significant difference, which statisticians use, but there is also the minimally clinically important difference that makes sense to the patient. And as a just an extra giveaway or tips, others here maybe are aware, but I will absolutely recommend this rehab measures. I put it now on the chat function, and I'll put it on the website as well. This is a website that has a very comprehensive analysis of outcome measures, certainly for rehabilitation of many neurological conditions. If you are thinking of I don't think I've come across the most comprehensive website that breaks down an outcome measure in its detail, the relevance, the changes you are looking for, what it means, and things like that. So if you are thinking of outcome measures applying in your practice, I certainly recommend these sites for you to explore. We can use ICF to identify the problems. You know, what we discussed is all what, in summary, in our sub note, we call them problem list. What are your problem list? So you can use the ICF framework to identify the problem list. What are the problem list? Pain, and you don't have to put them in this impairment, activity level, participation. It's just a framework to guide our thinking. And I just focused on laying the foundation. How you decide to use it is absolutely up to you. But it's just a framework to guide your thinking, to make you aware, to drive those processes forward. So you can just, in your notes, I know we tend to write problem lists, so you can put pain, muscle weakness, unable to walk, all those things can be problem list, and you can put them on those category of ICF framework. And that will also help us in deciding how we can structure our treatments that will support the patient. Thank you for those that have put in their examples, but I just want also to pause here and still ask the same question again. Think of just a thought. Think of your practice. Think of a patient. Think of any patient. What was the impairment addressed or you are trying to address? What activity are you trying to improve? Did it lead to a better participation in the life of the patient, or how will it influence the real life situation of the patient in their daily thought? And I think you've shared your example, so there's no need for us to go back. But it's something that I want us to be thinking, hopefully, going forward. And it's certainly not a break time because we had a break. And then I will pause here. Do we have any question before we move to the next stage? We have 2 more stages to finish. This is 3:30. So yeah, we have 2 more bits to do. Any questions so far? Nope. Okay. So my question is, when do we assess and why? Certainly we assessed on when the first patient come in contact with us. And probably during our treatment, we tend to gauge the patient performance and we document that at the end of our treatment. And it is expected, I believe, that at the beginning of our next treatment, we carried out a full assessment as well. We carry out a follow-up assessment as well. But when we are assessing the first point of contact with the patient, the question is, why do we assess and what sort of information do we want to get out of it? So if just roughly, what do people think in terms of the first assessment contact? What sort of information you gather? Why do you do that baseline as basic assessment? I know it's a ridiculous question, probably because all of us are practicing, but just to reflect, why do we assess at that first initial contact, and what sort of information do we want to get out of it? Any thoughts are highly welcome.
I think we do assess to have an insight of what brought the patient to us. So I think from the assessment, we can be able to say, okay, this patient came here with this and that. Basically, and also to arrive at what we are supposed to do for the patient.
Yep, thank you. Agreed, absolutely. So I agree with what Rabi mentioned. So we assessed, I think the purpose for the first initial assessment, if I to summarize it, is establish the baseline status of the patient and everything that follows in terms of arriving on how we can help the patients and going forward. And we assessed everything from the impairment, the activity, the participation. That is the expectation going forward. And the reason is to set goals and individualize plan for the patient. And as we go along during that intervention, we monitored how our intervention in real time. So when we are delivering that intervention during the treatment, we can adjust our treatment as we go along. That's why we are clinician. to see if there is any immediate changes or response to the quality, to the pain, to the fatigue. And so sometimes our assessment is not only the paperwork we sit down, we document, which we will do, but it's also responding to patient changes as it goes along, making sure that the exercise we've given to them during that period is safe and they can be able to tolerate it. And during that treatment, when we are figuring out the things we're doing, it allowed adjustment of our technique, intensity, and possible progression. And following the treatment, we now document what we've done. It evaluate the short-term outcomes, patient feedback immediately after treatment, how they feel, and things like that. I think it's good practice at the end of our session to just check with patients that they are okay to go. They are okay in terms of how they are feeling. To see sometimes there are functional gains you can get immediately. Sometimes some of them it's over a period of time. And to ensure that the treatment is effective or not, and to inform our next session. So just have a quick chat with the patient and documentation. And whenever the patient comes back to us, I believe we also, as professionals, just a quick now with the difference between the first and the last follow-up session is the first one can be thorough, very detailed, capturing the baseline data. But this time around, it's just the progress report update in terms of how they are feeling, what is the difference, and a quick notes to compare their current status to the baseline. And we can use standardized measures to measure their progress. Certainly, sometimes we can't finish assessment on the first day. We can carry that over. But the follow-up assessment helps determine if the goals we set at the beginning are met or not. If progress is being made or modification is needed. So I think in my mind, these are the major time point, although these are the sort of period, but the major time point we assessed is one at the beginning to just make sure that we have that good picture of the patient. But as we progress, we just do a quick follow-up. In terms of documentation, now it is possible, and I'm aware maybe some people have what we call proformas or templates. So your place of work might have a proforma or template for both initial assessment and follow-up, or they might not. But irrespective of whether you have a proformas or templates or not, the same principles applied in terms of the conversation you have with the patient, and you capture that into that proformas or template. Earlier on, I think there was one, I think somebody was, I think Adodoku was mentioning about a proforma that they have in their places of work, which is good practice. It helps to guide the conversation among those therapists, where it enables them to follow through the biopsychosocial model. But the proforma themselves don't work. We have to give life to them. We are the clinicians that work through them. But as a practice, I will highly encourage, if it's not something you guys have, to have proformas in your practice or templates, because that will ensure the consistency of reporting. Earlier on, we talked about the accuracy of reporting, the standardized format. We started this morning by looking at the context and concepts of clinical documentation. I think gone are the days where we just have a blank sheet of paper, and there is nothing wrong in having a blank sheet of paper. But I think people are providing a standardized format of assessment, and I will encourage, if you don't have one, consider one. I will share one with you, but by all means, I will be more than delighted to hear some of the brilliant examples you guys have in your practices. I would like to hear people sharing their thoughts in terms of the performers they are having. Now, these are all trust. Some of them might not be applicable to your context, but just as an example of what people are doing out there in terms of performers. So looking at my screen, or not. So this is an example of, and by the way, apologies to, I think there is it Ajero? He has been trying relentlessly to join. I'm not sure if he has joined already, but I know he tried severally to join. So this is an example of proforma. So when we are talking of proformas or template, it's usually where organizations designed a template. Now, all these templates follow the same format, the same principle. The same principle of SOAP notes, but in a different way. The same principle of biopsychosocial model, but in a different way. So you can see here is about expectations in terms of the admission date or the bio data of the patient. So the bio data of the patient, reasons for admission. So this is all our subjective that we SOAP note, the past medical history. Now this is the psychosocial model we are talking about. And this has some examples, might not be applicable in your setting. Now this is for stroke patient. Now, in this country, there is usually an expectation that every single person that has stroke, they have to be seen within certain time period. It's an emergency, and they have to, if it is ischemic, that has to be thrombolized because it has a subsequent impact on the patient life. I think within 24 or 48 hours, that person has to be had an MRI or CT scan, I think, and then thrombolized. So this is just an example of standard of performance that people can certainly think of in their practice. And somebody mentioned about this, about the cognition and mood, but when we are talking about informed consent, but also amongst our patients. Now, this was included. Remember, I told you earlier on about stroke patients in our presentation, because of their increased likelihood of behavioral changes. The performers captured that psychosocial aspect where right at the beginning, it's being captured to make sure that the patients are supported throughout their journey. And then the communication, which you probably work with the SLT, and then the assessment begins. And of course, you have the whole subnote conversation history of how it happens. The vision, which is the objective, we can talk about it later on. I'm not going to go in detail because you guys are expert in your field, and all those parts, the sensation, talking about different components of sensation, the proprioception, the stereognosis, the right or left, and the comment. So giving you that structure that you don't have to crack your head, just going through it, the upper limb, the coordination, the lower limb, the muscle strength, different parts of it, the transfers. So sit to stand, rolling in bed, standing, mobility, walking or not walking, sitting postural assessment. Now, this is we talked about the ICF framework, and this is where your problem list comes in. So this is what we're talking about. What is the impairment? Oh, example here, brilliant. Left-sided weakness. Let me increase it as big as possible. So this is an example. You can see they even have an example, left-sided weakness. So which the same thing we are doing. So now this one combines both, which is a typical example, activity / participation. And then they also have an example. And the example is transfers, unable to leave home to go to social event. So this is how we just integrate everything we've been talking in our day-to-day practice. And then from there, you can now think of what are the patient goals, hope, fears, and things like that. I think there are treatment, is it or not? Where is it? Yeah, so the treatment plan. So they have the goals, and then they talked about the treatment ideas, what to do about the patient and things like that. So that's an example of a pro forma. And I will share another example. So these are all different centers, but they all have the same thing. So it is standard globally. Now, this has started with the history of presenting condition. So the story of how it happens, which is our subjective that we call it. It's a sub format. What are the relevant medical conditions? The dominant side. So this talk about the muscle strength, easy beats. So talking about movements, muscle tone, posture, respiratory. So these are all our objective. If you want to put it in the sub format, this is our subjective, the first two. This is our objective assessment. And then these are all the informations working alongside the MDT. So we can see how the factoring of the life situation, the psychosocial aspect of how it affects the patient's day to day. This is the cognition, the same screening. Now they use a different tool, but it's the same concept where we have to take account because of the population we are dealing with and how it affects them and how will they function. Personal ideals, so thinking of the context, environmental context of their day-to-day lives, adding it all, and these are all the outcome measures that as an example of the performance, and then the problems identified. So think of the problem list we talked about. What are the problem list? The impairment, the activity, and the participation will go all here in terms of problem list. And then what are the patient goals? Trying to take the patient into involve patient in decision making. And then we talked about the short-term goals from your own perspective, the long-term goals, and then what are the interventions. So these are all examples of performance, just two short examples just to share with us, and then I'll come back to my PowerPoint. And I want to ask, what do people use in their practice? First is, do you have performance? If you don't have that, it's fine. What do people use in their practice? Is it, what do people use in their practice? What do people use in their practice? Sir, if you don't mind, I think Mr. Omotade Adodoku, earlier on you are mentioning about a pro forma that you have that in your practice where you, including your junior colleagues, everybody will use it. How does it look like? What is it like? Is it something you developed as a service or is it, yeah?
Now, it's not a complete performance like you uh, give, like the example of the ones you just gave us.
Okay.
But for example, we have muscle charts, a complete one to chart the muscles. But
Okay.
ordinarily, we expect the super format to be followed when you are documenting. So I'm of the opinion that what I've taken from this presentation, even before you asked me to talk now, is that we
Yeah.
develop the proper pro format so that it will make at least it will reduce chances of missing any of the assessment, any part of the assessment.
Well, thank you so much, sir. And it's really pleasing to hear uh, that you are taking away something from here.
Yes,
Um,
sir.
it's the concept of whereby even if it is one out of the 99 that you've gotten, that's a big achievement for me. So I'm really pleased to hear that.
You're welcome, sir.
Yeah. What I would say is with the performance, it's good for learning, it's good for intents, it's good for practice, and subnote is excellent. So there's nothing wrong with subnote, and we can use subnote. So what I shared is for initial assessment to give a baseline, not necessarily to use it for follow-up, but yes, you can use it for follow-up. For the follow-up, they can use the performance going forward. But for the initial assessment, I will highly recommend sort of a performer. Whether they use it or not is different case, but just to have an idea of questions to ask, boxes to tick, and things like that going forward. But yes, in terms of sub notes, in terms of going for follow-up assessment and things like that, using sub notes, which is what we will look at next, is what I will recommend. Is so you have a free templates that you can use. I am aware we've been talking. Usually around this time, we tend to go for another quick screen break. So this is 3:45-ish. Is there any questions so far or comments? Or maybe suggestions, or some people want to share their thoughts about performance. Apart from the Mr. Omota that share his own, what are other people using in their practice? What are other people using in their practice? I would be picking on people now. I think those is there anybody from FTH go? Yes, Irene. Yes.
Sir,
What do you use in your practice in
hello.
terms of clinical documentation?
In terms of like UBTH, we use the functional independence measure when
Okay.
assessing the functional status of the patient. So based on the different domains, we get the information from the patient and we get the total of it in order to know the kind of functional status that the patient is at that moment. Then from
Okay.
there, we will now like take that as our intervention, what to do
Oh,
for this patient, the kind of modality, the kind of ambulation hit for the patient.
but stay with
But
me,
in terms of the
Irene. Yeah, carry on.
in the geriatrics unit, we use the 4 weeks assessment tool. But the
Mm,
thing is that the major limitations there is that many of us we don't really use it. You just add it like on the billboard, so we don't
mm,
really know how to use it. So we just go into the Barter index scoring.
mm.
That's what we use at UBTH.
Stay with me, Erin. Please. What you describe, Erin, is what I
Sir?
will what you describe is what I will call outcome measures. Okay, outcome measures.
Okay,
So
okay, sir.
so
Okay.
do you have like a comprehensive performance, or how do you do? Assessment is beyond the outcome measures. It's about the story of the patients, apart from our
Yeah.
assessment. So do you have like templates performance that you use as a practice, or do you use a free text, just white paper and you write, or do you use the SOAP format?
We just use the ICF model. That's all.
Okay.
We don't have any other comprehensive format that we use.
Okay. But
Yes,
the
sir.
ICF framework, do you integrate it using the SOAP format, whereby you have the subjective, objective assessment and plan, I will imagine?
No, sir.
Okay, that's fine. That's fine. And that's the next thing we'll be talking about. Thank you so much, Irene.
Thank you, sir.
Yeah. Um, one more bit. What do people use in their practice? I think it's good for me to share what you do in your practice, because there is no point of me talking if it doesn't apply to you. So I want to tailor my conversation to what will benefit you. So what do people use in their practice? Anybody from anywhere really? What do people use in their practice? One more before we go on break. Certainly you've been writing for the patients. Certainly we've been documenting, and certainly you are not using it in your head. I believe you've been putting it on paper. So how do you put it on paper? I think we have Zalia here. Is it from FTH, Zalia? Is Zalia on the call? Maybe not. Okay. Zuleha, is it Zuleha? What do people use in their practice? Maybe not. Okay. So, okay, use outcome measure. So outcome measure, it's just one component of assessment. So assessment goes beyond outcome measure. It's good, Adamu, you used outcome measure, excellent. But apart from outcome measure, Adamu, Lawal, do you have like a comprehensive way to capture the whole conversation? So think of outcome measures as subset or part of objective assessment. So your conversation from patient, from the time they come in to the time they go out, do you have like a comprehensive, how you comprehensively capture that information? Adamu, you can unmute your mic or you can just chat in the chat function. What do people use in their practice? I think that's the height of today's conversation, just to make sure we have something going forward.
Do you mean the part where I ask the questions, or including the assessments I would make, the physical assessment and
everything? So when we are talking about clinical document, it's everything. So if
so
you
we
do
put
everything,
we put in form of clicking. We just take all the necessary information and just put it in format of clicking from the biodata down to the plan of the treatment. So it's just like a kind of format everyone use.
okay.
So everyone use that kind of format to document on patient's visit and the new clicking and all that.
Okay, so the clicking format, is it given to you by the department or the hospital?
Yes, I can say that one even started mostly from the school, and people
Okay.
stick to it until in the workplace. Like you start with the biodata, you move to the history, you move to the past medical history, all that format, and it's still the same thing that we are using. And I'm seeing less use of outcome measure, which I think is very, very important to the clinicians and also to the patient to track the progress of their condition. But it is often something that is not,
difficult.
it's very underutilized here. And everything is just being done in more of a kind of traditional way, just doing treatment, documenting the next day. If you see changes, change the treatment plan. But there is no a quantifiable measure of how valuable or how effective is a particular treatment regimen is being in regard to that very condition, so that we can have a kind of informed decision of which among the treatment plan is not working and which one is working. So I think this one is a kind more of a general limitations here, especially here in Nigeria, and this kind of engagement will be very important to a lot of clinicians, because it will make them to understand the importance of making the things be very integrated, both to them and the patient and the care plan at all.
Okay, please stay with me, Adamu, if you don't mind. So when you talked about clerking, of course, all of us are trained in clerking right from the university. So in terms of what my question is, so is it just everybody takes their training, because we train from different institutions, and then go and apply it in, just you will be given a white sheet of paper, or you will give it an A4, and then you just write your notes based on those subheadings that you have? Or does the sometimes but I didn't know if you are here earlier, I shared a template. Some organizations usually sit down and have a framework, because the clerking is generic, and I will come back to that, but there are specific nuances to the places you practice, whereby you want to capture certain information to make sure that it's not left at the mercy of who is seeing the patient, but there is that consistency across a practice. I didn't, so so I didn't know if you understand what I'm saying.
Yes, I get it. And based on that, I can say that the initial information we had right from school is is getting, what would I say, more weight when you compare it with what the standards that those hospitals are giving. For example, here where I am,
Mm.
every documentation is being done in computer,
Yep.
and people will virtually in the computer there are places, there are boxes desired
Excellent.
for example,
Yes.
musculoskeletal things, all those things. But then
Yes.
because people get habituated to the ones they normally get used to, so they
Mm.
will just find a way of putting, especially biodata in one place. Then under the history, then they will put all other the normal, the history, past medical history, all of them, put it in
Mm.
one place. Won't like mind much to follow it one after the other in the musculoskeletal, cardiovascular, and all those.
Yeah. Yeah.
Like people doesn't care much to follow it in that way. They just
Systems
find their
review.
way out to, yeah, to still use their existing system and still duplicate it into the templates that we are given,
Mm.
regardless of whether the columns support that or not.
Mm.
So it's more like the need for the encouragement of adopting those, or if, because sir, I can see it here in a two-way system. If that template is not that much suited to the
Mm.
various departments, there
Yep.
should be a collaboration between that department and the hospital so that it should be customized for that department. For example, here you might see some columns exclusively not for physiotherapists because the domain of our assessment doesn't even cover that. So someone will just feel like if there are such kind of incompatibility, then it's better for me to just use the format in my head due to the time constraint and all those, to just copy it and paste it there. So everyone who come and to view it will just see the information there, not just
Mm.
following the template one after the other.
Mm. I think I agree with you in terms of the format. So the format, it makes no sense if it is not applicable in local context. And I don't think it's best practice for a whole hospital to give one format for every department. Usually, physiotherapy will have their own format. In fact, even in physiotherapy, when you are practicing in neurology, you will have your own specific, or when you are practicing in pediatrics, there are specific questions that are relevant to pediatrics. So this is why I think that was what I'm saying in terms of specific to that context. But I understand what you're saying in terms of the broader categorization. But the last bit before I leave you go, it's the format you are having. Do you think it captures the biopsychosocial model framework, or is it on your head you try to capture the biopsychosocial model framework or ICF framework?
Yes, actually, it doesn't. One
Okay.
has to just in his head try to relate all that maybe in the history.
Mm. So apart from
Yeah.
the history, we need to include it. I think from the conversation we are having now is, when we come to problem list, you need to put it the ICF I impairment activity participation to make sure you put those what are the problems of the patient at that level and then help you clinical reasoning. But that's true. Maybe as a takeaway for you is just to raise the conversation with your colleagues and see how you can customize. I know it depends on how much hierarchy you are, but it's something you might consider not now, maybe in the future. Customization of templates that serves the local context and make sure that standardization across the settings.
Okay, sir.
Um, yeah, thank you
Thank
so
you so much.
much. Yeah,
Yes.
uh, it's 4 o'clock. I think I have very good conversation with everyone. So I will say let's go for a 15 minutes each break. So we come back by 10 minutes past 4. So it's 3:55 now. So 15 minutes screen break. We come
Mm.
back by 10 minutes past 4 to wrap up the conversation.
Okay, sir.
Yeah. Thank you.
Okay, sir.
All right. Good morning, or not morning. Good evening, almost evening past 4. Um, I know most people probably have dropped off, but hopefully they will rejoin. Session has started.
We are online.
Okay, brilliant. Thank you. Thank you. So let's continue. I think before we go on a break, we had a conversation, or we were having a conversation around the clinical performance for documentation. I think what we have spoken consistently throughout today is the need for us to be professional in our approach. And if the popular saying, which I started my conversation, is if it is not documented, it did not happen. So the fundamental conversation is documentation is not optional. It is a must for all of us, clinician professionals, highly recommended. How we go about it, there are variations in practice. Yes, there is the standard formats of the biopsychosocial, but are we actually factoring biopsychosocial, where we take the subjective information, including the social history, family history, but are we applying it in practice? I think that's what I highlighted today, or I'm trying to highlight today. And what is presenting on my slide or PowerPoint is that there are practices that have what we call proformas. Now, proformas are used to encourage standardization across practice. They are used to enable communications. They are used particularly for those that are young into practice to support their progression in learning. Apart from those, so there is this initial template for assessment, but also there is a follow-up assessment. But irrespective, I think there are different formats, but I think one of the widely accepted format is what we call the SOAP note. So as the basics, or when we are doing clacking, as has been called, is as the basics, we tend to follow the SOAP format, where we capture the biodata of the patient. And in the SOAP format, we can touch on the biopsychosocial aspects. What is the physical derangement? What is the social affectation? And possibly the psychological impact to inform our objective assessment. And I don't think I will now. I deliberately did not put emphasis on SOAP conversation or format, rather than on the background of what informs the SOAP format, because I know most of you are expert, and there is no point in going through this in detail with you. Hopefully, and please bring to my attention if that's not the case, everybody, this is not the first time you are hearing sub format. I believe so. And hopefully, most of us, when we are doing clacking, we are using the sub format. Now, the sub format is an acronym of the S stands for subjective assessment. The O stands for objective assessment. The A stands for analysis of findings or assessment or examination, evaluations, whatever terminology. Some people use E instead of A, and it's called evaluations. Some people use E, examination is the same thing, and then the plan of action going forward. Now, the subjective, it's simply the conversation you are having with the patient. So any information that you think of that you're capturing about the patient telling us the story, everything falls under subjective. And that starts from maybe what we call the presenting complaint or the chief complaint, as others may call it, whereby the patient tells us what are their current problems, what they are able to do, what they are not able to do. And it moves to the history of presenting complaint or condition. Now, the history of presenting complaint is to paint a picture of the progression of the disease, how it happens. I feel the history of presenting complaint, it's an opportunity for us to understand the mechanism of injury, especially for MSK patient or those that are practicing in MSK, because the mechanism of injury will start to inform your choice of objective assessment and tells you what is the likely injury that the patient is having. For example, if there is a trauma in a particular direction for sports people, let's say from behind, and the knee is fixed, then you start to think of anterior cruciate ligament. Because if somebody hits, the likelihood that somebody hits your knee, your foot is planted on the floor, then that ligament, that anterior translation, the ligament couldn't hold it, and then it stretches the ligament beyond repair. So yeah, it's not that patients, we are interested, of course we are interested in their well-being and everything, but the history they are telling us, we have to shape it to the information we want to extract. Certainly, I have come across a patient who, and I believe most of you, who can tell you a whole story of super story or from January to December telling you stories. But your ability to redirect the patient, to fine tune to the direction of information you want, that's the skills that I believe most of us should have or are developing to have. So the history, which is part, so the first is the chief complaint or the history of presenting complaint. The history of the presenting condition is the second one, which tells us a story leading up to the illness. So I usually have like a timeline trying to in my head. So before this illness starts, what is the functional status of the patient? So that it will inform me how the patient will be able to progress, or what is the target that if I'm pushing the patient to achieve. And then from that point, where the patient, from that point, where the patient has started the problem, how does the problem progresses? How the symptoms progress, have they seen progress or not? What are the medical inputs and things like that? All those things formed the conversation. And the patient, our patients are complex, I will say. There are multimorbidity. So the relevant medical conditions, just to give it a context, because you want to not to cause harm in terms of helping the patient. So there are also other medical conditions that may be affecting the patient that you want to take into consideration. And what are the medications they are taking or allergies? Medications or allergies, so drug history. For example, Parkinson's patient, you would like to give them, apply your intervention when during their on period or something like that, when their medication has kicked in, because Parkinson patients that are in advanced stage have the likelihood of their movement disorders will affect your rehabilitation. So these are information you want to get out so that you can apply it in your rehabilitation with the patient going forward. We talked about social history, talking about the type of accommodation they live in, their sleep, who they live with, all those information, and so that you will know who you want to contact and support their employment, their leisure. For MSK, I think one of the, and also for not even MSK, for every professional, is what the red flags or the flags. There are red, blue, black, all those flags that affects the patient. Red flags, we should know or all know that it's an emergency. Example, quadra equina, unexplained weight loss, all those things. It's something that we should quickly escalate. And once you've gone through so all these are information, subjective information, patient telling you their stories. How we ask the questions matters. How we ask the questions matter, because the same patient, if a therapist A meet the patient and therapist B meet the patient, the information might be different. And what is being encouraged, and I believe most of us probably are applying it, is the use of what we called open-ended question. You don't want a tick box approach, or you don't want to box the patient and give them a view. You use predominantly open-ended question, and then where possible, you confirmed by sort of a closed-ended question. And that's why we start, can you tell me what have you come to see me today? Very broad. what have you come to see me today? Yes, just the patient telling you their story. That's in the initial assessment if you don't know. In the follow-up assessment is the question of, oh, how are you feeling today? What has changed? Just open-ended question. And then the patient will tell you their story. Now, I certainly remember when I was in my training, my mind is fixed on, oh, I need to start with presenting complaint, history of presenting complaint, drug history, relevant medical history, family history, social history. But in practice, and as we practice, and probably the experienced clinician will tell us, is it doesn't, you just have a conversation with the patient whereby the patient will just tell you their story without a flow, and you put those information when you come to sit down and document, you arrange those information under their headings, but the patient will not necessarily tell you their heading. And sometimes you need to go back and forth. So it's not a linear conversation of information you get from the patient. It's a back and forth conversation trying to fill up the gaps, patient tell you their story from start to finish, and then you go back and fill up the gap. If there is something we talked about is patient-centered care. And in the subjective bit, it's always recommended to ask the patient the perception of their own problems, or what are their goals? What are their expectations for this treatment? Because if their expectations is unrealistic, it's better you start managing it right there and then to manage the conversation. So what are their goals? What are their expectations? What do you want to get out of this treatment today? What do you want to achieve? What do you expect from me? So a question that will wrap up the conversation, empowering the patient, feeling like they're being heard. It's about them, and you're working towards to improving them, but also to give you an insight into their mind, into their ability to recognize their limitations or not, so that you judged what to give your patient or not. So it's good to start chief complaint, history of presenting condition, relevant medical history, social history, all those things we do, and wrap it up with patient expectations or goal. And that's it. In terms of the subjective, well, like I said, it all depends. Some places like the pro forma I shared, sometimes you have a pro forma that guides you through the conversation. Now, the objective, it's where the subjective is the patient story. The objective is now your own objective findings and to a certain extent your outcome measures, but it's about confirmation of some of the assumptions you may have from the patient stories. And still also casting my mind back when I started practice, sometimes we all like to put the textbook definition of all the objective assessment on the patient, which by now most of us realize that it doesn't apply. You have to prioritize and identify certain objective assessments that are relevant to the patient, time for time's sake, but also space. You don't have the time to go through all those bits. But as a general principle or guide, we tend to go through general observation, and that observation, in my thinking, in my view, it doesn't necessarily start from when you sit down and finish the subjective and go. But even when the patient is coming in, if it is an outpatient department or you have an office, is looking at how they are walking, looking at their contact. So general appearance, how they are walking. You observe things and you can document those bits. The color of the skin, their breathlessness, if they are talking, general observation. And the palpation. Now, palpation is just applying a general slight overpressure to the skin or an area of the body where you feel the abnormality is. So you make assumption, or they tell you, oh, I have a pain on my lateral hand side, and you want to go to the lateral elbow and just palpate and see if there is any, if it's tender, if it's painful when you eat, if it reproduced the symptoms. The temperature, you can feel the temperature, see or any swelling. And then we move to probably the sensation, and the template I've seen shared, that's when you see some of those sensory tests that you can do. sensation. One of the absolute out tool that is very comprehensive in sensation that I will recommend is especially for neuro, is the Nottingham Sensory Assessment Skill. It's very comprehensive, and once you can lay your hands on that, have your head around it, I think you have covered it very well. And that includes coordination, 2-point discrimination, hot and cold. All these are part of sensation. And that's the proprioception and proprioception, I mean. And then you do the coordination. We tend to do visual tests. Now, you can do visual tests as neuro in terms of testing for the hemianopia or depth perception, but also I believe all as a physio, we just have to quickly make sure, especially patients that have eye problems, because it can affect their ability to walk, risks of falls, especially the elderly. So it's one part that we might not necessarily implement a rehabilitation in it, but we can identify the safety risks for the patient, and we can certainly make referrals or make advice to the patient on what to consider during their rehabilitation. Our range of motion, so we assessed all those passive range of motion, active range of motion. The MSK guys also assess the accessory range of motion. Our goniometer, I think earlier on we are talking of outcome measures. Our goniometer is an example of an outcome measure to assess, but certain parts of the body, there is what we call inclinometer. Inclinometer is also used for range of motion. And then our almighty strength testing. Throughout today, I see a lot of people mentioning strength testing, the manual muscle testing or Oxford muscle grading scale. And functional assessment. Functional assessment, when I've mentioned functional assessment, it's about the gait, it's about the balance, both sitting and standing balance. It's about the posture. All this falls under functional assessment. For MSK also, we can go further and do spatial tests. I think somebody did share their spatial test here. Spatial tests, all those provocative tests that you will do to confirm the assumption. So yeah, that's objective assessment. So objective assessment, we start observation, palpation. It depends also, sensation, range of motion, movement, muscle strength rather, functional assessments, balance, sitting, standing, gait analysis, what the patient can do, can't do, transfers as well, and the special test for MSK bits. And you can do, people add problem list here, some people add treatments here, which is fine. There is no really a standard bit. I would say it's fine if people want to put things here. The analysis of finding is where your clinical reasoning comes in. Now, some people put their problem list here, looking at the ICF framework. Some people put it in the objective assessment. Some people put their problem list here, including the so the problem list, the general impression, what you think is the problem, and some of the recommended sort of start-off plans. But the analysis of findings, principally, in summary, it's a process of deciding, is the clinical reasoning and decision-making section, where some call it evaluation or assessment. It's based on the conversation you had with the patient, the subjective information, the objective information, synthesizing both this information and making sense to the patient, but it's mainly for yourself, and how its impacts on the treatment and how patients respond to it. And when you are doing your follow-up assessment, particularly, this is why you will mention about the progress of the patient, the reaction of the patient to treatment, how do they report to treatment, what possibly influence the patient response to treatment. All these things are something that you can add in here. For example, functional limitations, reduced balance and mobility, which increases patient likely risks of falls and limiting their independence. So it's about what are the possible impairment that limits the patient activity and participation. So if you can link it here all nicely, whereby patient is unable to go out or due to muscle weakness or something like that, or difficulty walking, sit to stand. Or maybe their psychological status. Patient is very confident, or patient appears fearful, or patient has reduced confidence due to history of falls, which impacts on their rehabilitation. Or patient engaged today and doing well, able to do this, or patient has variable status. All you can just make some analysis of findings based on what you think of your treatment. And then you come to your plan where you outlined what will you do next based on your analysis. It is the actionable part of the note. And this is where you can also be very specific in terms of your treatment, what you will do during the session or future session. For example, manual therapy for lumbar or core stabilization exercise, patient education, how often, the frequency, 2 sessions per week, and then home exercise program. Always consider home exercise program for your patient. Those that are not outpatient, always consider what I call ward exercise program. In addition to the clinical documentation, the notes I've mentioned, is good practice as an organization or center to consider a template where you can have some exercise sheets and give to your patients. And there are free websites where you can create exercise online and share with the patient via email, or download it and share with the patient. It's important. We encourage that going forward, but just to mention. And if you need a referral or further investigation, this is where you probably want to consider that. You can also include the short-term and the long-term goals here, and then sort of the plan going forward. But like I said, you can bounce some of those information either on the plan or on the analysis or the treatment bit. So having quickly chatted, what I will ask is, I think we talked about, so thinking about your practice, I call it start, stop, continue. Well, not me, but it's a good reflective piece of things for us to be doing. Looking at your practice, all of us here have been practicing, so there is no exception. All of us here have been clinicians. All of us here have been helping patients, but we want to do more. What documentation habits generally do you think you want to stop? What documentation habit do you think you want to stop? It can be maybe an incomplete note. You just write a note, but you didn't complete it and you leave it. It can be a jargon. So by jargon, I mean irrelevant information that if one is not relevant to the patient, or maybe it doesn't make sense. It can be, we talked about, for those that had joined us in the morning, we talked about the contemporaneous nature of note taking, whereby you write notes as at when due, so that your colleagues can take over the notes that you've written. And so it can be something that maybe you don't write notes in time or early, but what is it that you want to stop? Habits you want to stop going forward. You don't have to share it. It's just a reflective thought for you to write it down, or maybe to contemplate in your mind as one of the takeaways from today's session. But what I really want you to tell me is, what do you think will you start to use for your practice, if there is any? From today going forward, is there anything that you possibly want to take and integrate in your practice? It might be something you are doing it, but just to ramp it up. And secondly, what I really want to hear from you is those good habits that you are doing. So having gone through the conversation today, certainly there are good habits from the conversation I had today. And I've picked a lot from you guys. What good habits will you like to continue? E.g., patient-centered language or being empathetic. We talked about being empathetic, building trust. It will be good for you to share your thoughts. One is the things you will start, two, the things you will continue, so that all of us will learn from each other. The microphone is yours. If you want to chat, you can unmute your mic or you can put your conversation on the chat box. I'm still listening. What are those things that people want to start doing from today or continue doing? Good practice that they've been doing. Come on, it's your opportunity to shine. I believe you guys are expert in your own field and bread and butter. Thank you. Okay, be more patient-centered in my treatment. Thank you. Oh, yes, thank you. Keep the conversation coming. Yeah, practice informed consent. Okay, I see. That seems like you've taken the whole of today's session. Thank you, Jennifer. Thank you. What do people want to start taking going forward or continue? I guess it's more relevant for those that are clinicians. Those that are not clinicians. Okay, outcome measures. My Oga says outcome measure to track progress. Thank you. I think Adamu, your clarion call of the use of outcome measures, it has been heard loud and clear. I think Rabi mentioned about use of outcome measures. No, thank you. What do people want to think of start using? I think we have Abubakar Abdullahi or Abdullah Abubakar. Any thoughts from you? We have Mariam, Uche Anegu. Any thoughts from you? Awal Abdullahi. Any thoughts from you? My boss, Mr. Bayowa. Any thoughts from you? Enoch. Any thoughts from you? Hilary Okechiku. Any thoughts from you? Idris. Any thoughts from you? Irene, I know you've added to your conversation throughout. Any thoughts from you? Jibril, Quila, Kitibo, Monijesu, Oladele. Any thoughts from you? Chigoze, Obinka, any thoughts from you? Chukwuemeka Ozo, any thoughts from you? So what do you think? Thank you. Keep them coming. Always give a pictorial home exercise program to my excellent. That's good. And yeah, maybe there's a different conversation. There is free website that you can have those exercises both in pictures. You agree with the review. Excellent. I think that's a brilliant idea, Jennifer. There are unlimited outcome measures, but sitting down within your department and agreeing on what is the common outcome measures that you can use and apply, that will change your practice. You can take one or two and that is it. And one of the problems, which I think it's the application of practice outcome measure, is the complexity of outcome measures. We will do a session on outcome measures maybe next year. But think of very simple outcome measures. Doesn't have to be those fancy equipment, those big equipment. Anything that will measure the progress of the patient, that you can measure it in a standardized format. Even if it is just the ability of the patient to stand up and sit, let's say 5 times. So think of very simple, straightforward equipment, less outcome measures that you will apply. That is what I would recommend. Favor mentioned due to lack of, okay, maybe that's a little use of proformas, right question specific to patient condition. Yep, thank you. I think Miriam mentioned informed consent and outcome measures serious. Okay, in and observant of my of care and talk with them instead of seeing it as business and not. Oh, excellent. Yes, yes, good. Involving them, not involving myself with it. Good, good. Thank you. I think that's the approach. That's the approach that I really want to promote. That comprehensive nature. It's the influence of everybody in the care of the patient. We'll see outcome measures as taxing, but this okay. Oh, thank you so much. I will give a heart to this one. Thank you. I think outcome measure can be very simple. We don't have to link up this big equipment. Thank you so much. I think keep the thinking forward. Thinking about it forward in your practice. The whole idea is start, stop, continue. And this is a cyclical process. After today, after 1 year, after 2 years, it's something you, if you want to progress and make it very fanciful for you professionally wise, I think it's something you want to reflect and continue to build yourself. It's not okay for us to be doing business as usual. The world is moving, and that will take me to my next conversation. It's important we think of how we keep on revolving with it. Digital documentation. Earlier on, Mr. Adamulawan mentioned about the hospital have provided a electronic platform where all of them are using those digital proformas, which is good. But it comes with its own challenges. Digital documentation is basically refers to any information, so the recording, storing, and managing information in electronic format. We have been using that. There are different time points, but I know now people are moving towards that. So rather than paper and pen, certainly I was trained in Nigeria using the paper and pen. And yes, even now, there are certain places in the Western countries that are using paper and pen. So paper and pen is not necessarily going away. They are still using it everywhere in the world. It's not only probably in your context. Paper and pen are still being used anywhere in the world. However, the way to go forward is using a digital documentation. And it is important because it improves the accuracy of the notes, efficiency. Hopefully, is a question of typing, but it is meant to be efficient in terms of not only how fast you type, but once you have it, you can crisscross pass information, and it's accessible. So once you finished, bam, somebody from the other end of the world, if you are using a cloud system, can access it if they are on the same platform with you. You can share that information depending on how intuitive or interoperable your platform are with other organizations. If you are discharging, making referrals, and it will reduce administrative burden and human error. I've in my practice certainly come to plan when I was writing where I have to cancel, I have to tear the whole sheet of paper and rewrite again. All you need to do with digital documentation is just go backspace, delete, and then that's it. And it makes it easier for compliance where If you are expected to make documentation, you can comply with it, all those regulations. Confidentiality wise, for example, or privacy, where if I type my note, I can log it, password, that's it, rather than paper and pen, which I forget, I put it on my desk and there is no key on my desk, or I don't have a locker, and then patient information is exposed. And current advancement, there are lots of cloud-based systems. So now the world has moved fast. There are a lot of cloud-based systems where it enables remote access of real-time of information or patient data in real time. You can use your mobiles now, mobile friendly, where for documentation, you can do it on the go. I know certainly when I started practicing in this country, it's where we have to carry laptops. I know it's still laptops and everything, but just to let you, there are mobiles where you can do documentation on the go for many things. And for those, there is also blockchain. Now, blockchain or blockchain integration. It's a ledger and people are using it now. It's very tamper proof, very secure storage. And there are technologies that you don't have to type. You just speak to them. Like now I'm speaking. So whatever I've done with my patient, I will just pick my phone and then speak to it, and then it will type the note for me. Very fancy. So converts speech to text. And all those things are advancement in terms of the use of digital documentation. And there are pictures here. It's sort of examples of tools that I've used, or tools that I think I'm aware of that you can use. But again, it's the question of compliance, patient consent, and things like that. So the question is local adaptation in terms of using it in our practice. It's important that some of those things, of course, there are difficulties and realities of how we can apply it in practice, but just for us to apply it, well, this is what is obtainable, and it's for us to start thinking of how we can use it in our practice. I will come back to this picture, maybe when I come back to my next slide, those pictures underneath. And AI, certainly, the use of AI has made it even more fancier. So it's not only enough for you to type and record information. Now, in AI, within the last 2 years, AI has changed and has moved rapidly. It's not a question of making us lazy. I think it's a question of making us efficient. The conversation of use of AI has moved past the stage whether to use it or not. People are embracing it. Now, AI will convert automating documentation by speaking to it or dictating it. You will just get your notes, your sub notes, capturing everything you've done with it. So, as an example, you went and see a patient today, and patient tells you their story, and you want to write your notes. You just have the software on your phone, and you just talk to it, or you are driving and you will be talking to it, or maybe not. If you are in the community, you just talk to it, to the software, and then it, before you know, it captures the whole information and write your note for you. At the same vein, you don't have to talk to it as in after your session. You can use those softwares whereby with the consent and regulatory requirement, you just on it. So you have it on your phone, you on the software, and then you sit down with your patient and you talk about everything in terms of the treatment, the assessment, the subjective assessment. You carried out your analysis and everything. So that's the ambient listening. So it will be in the background, passively recording your session, making it super easy for you. And it will extract only the relevant information, filtering out all those non-medical jargons in the conversation. And at the end, you have your notes. All you need to do is, maybe if you do your objective assessment, you just edit and add those objective assessment and then upload it. And yes, there are softwares, some of them are even free that you can use, although the functionality differs, that you can use in your practice, where you just use those software and in a day-to-day practice, if you have a smartphone and things like that. And it can track progress, analyzing notes over time, all those objective measurement that we talked about, the outcome measures, the range of movement, the muscle strength, the function, all those things it will tell you, it can give you an analysis, a quick analysis of where your patient sits, how they are progressing and things like that. It can even make suggestions for treatment, evidence-based protocol. But I know for this one, I will say it's still at the early stage. Based on my experience and what I've seen, it will require you to modify, to edit, because it's not the human version. So yes, it will make a recommendation for you, but I think it still requires a bit of more input from you as a therapist. And certainly for the hospital, I think they find it easier for billing and compliance. It's easy for organizations. And if you are in a private practice, I will recommend, it depends on how big your practice is. I will recommend using softwares that will help you automatically generate, not only to write notes, but help you with billing, communication. It makes you look professional, presentable, and makes you appealing against your competitors. Is there anything else people think of use of AI in physiotherapy that they want to share? Is there anything people, all the techie guys in our midst, that they want to share on terms of the use of AI or their experience? What are people's experience on the use of, let's say, the digital documentation, but AI in specific? What are people's experience? Yeah. I certainly am not the most techie guy in the platform, I believe. So I mentioned about examples. So the first picture that shows a microphone, and the last picture, the dark one in the background, is a software called Heidi, HEDI, is a Heidi Health. It's an AI scribe note that I can put the link here. Not that I'm recommending or for them, but I know it's straightforward. You have the software in your phone, as well as you can use it for, yes, I've put that. So Heidi application, it's certainly, I found it intuitive. One, like I said, you can practically be driving and talking into it. It has specific SOAP notes template. It has so you can decide to choose a SOAP template, and it will put that information into SOAP note formats for you, straightforward. Or you can decide to ask it to give you a free text conversation, and it can put those free text conversation. And I think it seems to also understand physiotherapy a bit more, because it gives you that physiotherapy, all our documentation, how we write the physiotherapy, it tends to pick up those conversations. But you don't have to speak to it. You can own the Heidi format in terms of documentation. You can own the Heidi software in the background with the patient consent and approval and everything. And it will capture your conversation throughout. And you can see how it records those conversations. So think of a note taking whereby you don't have to rest the pen. The most you can do is just press on and off, and then it captures everything for you. But whereas you will go and edit and adjust and things like that. And the good part of it is, the last time I checked, you can use the free version, and it will serve all these purposes I'm talking about. The free version will do all those things for you. So that's one software that I think, certainly if you want to go in the direction of using a digital platform for your notes as an individual, there are lots of functions. I have not try it, but the simplest one is just as an individual taking note. If it's an organization or if it's a private practice and you want to use like an electronic management platform. Now, also I'm not advertising for them, although I wish they had sponsored my training, but not. Is the Zenda guys, so the Zenda Health, or Power Diary. Their name is formally called Power Diary, but I think they are bought over. Now, it's an electronic medical record platform, so they are more robust. For them, it's about everything that you're doing. So think of the same note-taking and systems and processes that all the medical records that is being done in our own medical records department, in your hospital, in your facility. So this Zenda will do it for you. From the point at which the patient will just contact you, you can integrate it on this Zenda platform to the point whereby you will send an email to the patient, you will send a billing to the patient, you will write, your clinicians will write the notes to the patient, notes of the patient, to calendar booking of appointment to the patient, everything. So the soft is a practice management platform that you can use it. And I would say if it's something you are looking at, in terms of free version, I think there is a subscription, although they tend to, it depends on they may have a trial version or not, or you can request a demo. Yeah, there is a free version, but I'm not sure how much functionality you will be able to use with the free version. I think Diamond, okay, you just put the Heidi app. Okay, thank you. So these are all the software I would certainly recommend in terms of AI in physiotherapy or applications. In terms of, I think somebody mentioned about home program or exercise program. In terms of giving your patients home program or exercise program, and making it professional and appealing, or trying to send them via email. Now this is a digression. I would recommend Help2Go. Now on Help2Go, I think it's straightforward. There are lots of physio tools and everything, but Help2Go, you can use the free version. You can have an exercise. It's very professional and it's relevant. You can use it for your practice. Certainly, both private and government practice, I would say if you don't have anything, rather than scratching your head or writing notes and exercise for patients, as an organization, you can print those exercises and then be dishing out to the patient. Now, with these things, AI, the risks and ethical implication, now the accuracy issues, talking about the use, while we encourage the use of all those softwares and platforms, but we have to recognize they are at their early stage of development and evolution. And some of the AI generated information, certainly they are not accurate. I can say that for sure. And the notes can be erroneous. You have to review those notes, but at least if typing is not your skill sets, that takes away the typing for you. There are privacy concerns that probably you want to also be aware of, because data storage by AI providers, that can be breached. And is the question of patient identifiable information. Certainly don't try to put a lot of your patient identifiable information if you are using all those Zenda, but if you're using, not Zenda, if you're using like a software like I did, but you can, because they make provisions for that, but just for you to be aware of and the laws around it. The implementation barriers, some of them are free, but it's just the figuring out how to use it. Some of them are not free. It's a figuring out of the resources. And if it is a luxury, I would say, in certain settings, it is a luxury. And AI does not, I will repeat, does not replace so far at this stage, and we don't know the future, but it does not replace our professional judgment. And unchecked use can lead to risks. I think you probably want to be aware of there are also some false narrative. There are mistakes like I talk in the records and things like that. The ethical consideration or how to use it is the informed consent. And Rabiu mentioned earlier on in terms of the ethical dimension of recording patients earlier on. And it applies to this as well. Patients must be informed about AI use and consent obtained. I don't imagine as a professional, I will recommend you going and then recording patient conversation without asking them just because you are the professional and you're there to help. Let's always, before you record the conversation, before you need to, that's if you want to use it as an ambient listener, active listener in the background, always let the patient know that you are recording this, and then if it's happy, and this is what you're going to use it for. And whatever it generates, we as professionals remain accountable for the accuracy of the note. We remain accountable for the accuracy of the note. And make sure we sort of are aware of it. Yeah, but again, apart from that, I think it's a way to go. It's certainly the way to go. And it doesn't have to be fancy. You can start exploring it in your own small cocoon by using those free software to see how they can make your work life easier and make it very quite efficient. Just also as just a thought while we try to wrap up the conversation is, what are people thinking? What are the barriers or enablers, I would say? What are the barriers or enablers of that exist in your practice for digital documentation? What do people think about digital documentation, AI? What are people's experience? What are the barriers, if there is any? Or people can share their successes of what they are using in practice. Come on, you don't want to keep us waiting. We want to all go home. What are people's thoughts around it?
I think in Nigeria, the barrier for digital documentation is stability of network and internet.
Oh,
Because
yeah,
a
that's true.
patient, I have that experience because I think I was enrolled, I enrolled my NHIS with ATBUTH.
Okay.
Many a times you will go there for even the health record to be able to send your information to the nurses to take vital signs, then send to doctor's office. It takes a lot of time. In fact, patient will be there for not less than 2 to 3 hours just because of network issue. So I think stability of network is one of the barriers.
Wow. So sorry. Sad to hear about, well, I know about Nigeria, but it's very frustrating. Sadly, it will discourage even me to use it because, but I think it's also well, yeah, it's very frustrating because I can't imagine 2 to 3 hours without not the treatment. Yeah, thank you. What are people thoughts? Is there a way to go about those barriers? Well, maybe government investing in infrastructure of cloud system, but what are people thoughts generally? Okay. Vera mentions, depending on the location, they might not know how to make appropriate use of it. Okay. Yeah. Training, competency can affect the use of it. Yes. That's good. Thank you. It might take some time, but certainly we'll get there. Any more thinking around this? And what are people's thoughts? Thank you, Vera. Thank you, Ravi. What are people's thoughts whilst we wrap up?
Yes, again.
Yep.
Good evening, everyone. Yeah. Yeah. So in some setting, infrastructure is also an issue. Like rightly cited. Again, the issue of regulation and governance
Yep.
is another one. The risk of data breach
Yep.
is also an issue setting. So personally, I've been exposed to the use of digital platforms
Okay.
where I practice currently, and there are policies around the use of AI.
Okay.
My company recently published a policy around the use of generative AI.
Okay.
And for the time being, they discouraged us from such use until they approve particular ones for us to
Software.
use. Yeah. So there are a lot of red tapes around my practice that even though you know about certain things, you can't use it until they approve you, and you have to go through the training because you're responsible for. Again, the risk of data breach.
Yeah.
Again, you spoke about consent.
Yeah.
Patients should, while you're using it, you have to explain it to them. You tell them that, okay, if you give them more time, you get to create more rapport, time typing. Yeah, because we're all trained to be physios in our background, but when you come and you're doing a physio work, but you're also sharing it, typing. So you find out that you don't really have to share that time, admin time with clinic time. So we know the advantage, but there's a lot of, as you rightly mentioned, these things are still evolving.
Yeah.
So we don't know A to Z of it. Yeah. So just some of the highlights, but overall, we use the exercise prescription. Some of our exercise privately through some of the softwares, and they've really been helpful. They are very fast.
Yeah.
You can have templates for back pain or for knee. So as soon as you finish in the patient, you go on your template.
Yeah.
Already you have them set once you are not relevant for the patient, and you send it. So within 30 seconds, you send relevant exercise to the patient, and you can monitor his progress because sensing the link. Whenever he's engaging on the program, there are questions, there are outcome measures, using it or not, something like that. So it's very useful, except for the red tips around the usage.
Yeah. Well, fantastic. It seems like Mike has captured succinctly the both sides of the conversation around digital documentation or digital platforms in practice, as well as the advances that the use of AI or the roadmap to the use of AI. And certainly, like people have mentioned, the restrictions around that exist, especially in context. But there are also things that we can take away, like the certain exercises, depending on allowances, you can consider it in your practice. Thank you. So brilliant. Yeah, just to wrap up, I'm going back to my initial conversation. I think we are coming to the end of today. One of the focal things that we discussed today is these two models, and we have already covered it to put it out there in our faces is the question of what model are you going to be practiced in your services going forward? And I think people have put in their thoughts and their thinking. So thank you for those that have put in that bit. But I want you us to think of that going forward, that our patients, active participants in their rehabilitation, we need to involve them in the rehabilitation journey. It's not enough for us to be paternal, to just look at their biological context, but the psychosocial factors influenced their injury or their rehabilitation journey, and that will make or mar the success of rehabilitation. And yes, all the best with whatever you guys have taken away from today and you applied it. I will leave the platform for question. I can see hands is up already. So I think that will conclude whatever conversation we are having today. And I will invite question. Yes, Vera.
Good evening, sir.
Yeah, evening.
Can you hear me?
Yes, I can hear you.
Okay. Thank you for the broad explanations. Sorry to take you back.
Okay.
My question is based on assessment.
Okay.
You know, when you must have done all the necessary assessments, the objective assessments,
Yeah.
and you find out that a patient have this chronic or severe, let me take for instance, osteoarthritis.
Okay.
And you know, when you must have asked the patient their expectation and all, which
Yeah.
also have to be realistic.
Yes.
I'm asking, is it not advisable that you refer the patient to, let me say, an orthopedic surgeon for possible total knee replacement? Because the physiotherapist might not really do much in such situation.
That's a good question. I think I have experts here on the platform. I'd like them to start speaking before I add more. Mike, do you want to speak on this?
Sorry, I was a little bit distracted, so I didn't really get the full question. Would you mind coming again, please?
So the question is, you have so in the morning, I didn't know what time you joined the conversation. So we have journeyed through assessment. We start with the principles behind it, by all the models. We talked about professional expectation, but in particular, we talked about assessment generally. So Vera is asking that if you've come across a patient and you go through the assessment and they have chronic knee osteoarthritis, so one of the assessment we talked about is patient expectation. So and that has to be realistic. If the patient, based on chronic arthritis, as a therapist, is it not better if you refer the patient to orthopedic consultant? I think the word that I will come back to it if Mike didn't is for a total knee replacement, because you feel more or less it's chronic knee arthritis. Why is it not better to manage the patient expectation rather than just them coming back to you?
Okay. Okay. Thank you so much. Yeah. Yeah. Where I practice as a musculoskeletal physiotherapist. So osteoarthritis in its chronic stage, we don't only rely on the X-ray investigations. We also measure how it's impacting patient's life. So the image alone is not enough. There are instances where patients are able to cope with advanced arthritis and they still carry on with their lives. So in that case, you might not, and they don't want knee replacement. So in that case, you just keep managing them conservatively. However, if patient's expectation is because it's impacting his day to day, he can carry on basic things, and you feel you've reached the plateau of rehabilitation, there's nothing much patient can achieve. Yeah, it should be realistic to refer this patient to the orthopedic for them to have a look at it as well. Yeah, I don't know if that answers.
Yeah, thank you. Yeah, so just to add, I think just to start from your question, and then I'll bring in Mike's point as well, is orthopedic replacement or knee replacement, it's the last, well, it's been considered the last option for management. Usually conservative management is highly recommended. And the suggestion which Mike mentioned is for the knee replacements to happen, then all option has to be exhausted. And knee replacement happens when there is substantial impact on the patient's life, whereby they cannot cope going forward. And of course, they are willing to undergo that. So that's that part. But again, your description about a chronic knee arthritis, in terms of the patient preferences, one, yes, as a professional, the answer is yes, is a straightforward yes, in terms of you managing the patient expectations. However, is the question what you want to capture is how much it has affected the patient's life and whether the patient can be able to continue with conservative management with the osteoarthritis before that ultimate referral happens, where if the patient can no longer continue. And if you are making that referral, I don't think you probably want to give a definitive conclusion of joint replacement. However, it's for the consultant to review, but you might say these are the options available. One is we don't know whether I answer the question. And two, do you want to shed more light in terms of have you exhausted, do you think that you have exhausted the conservative management? And is it the patient that wants to go forward, or is it your judgment you feel you can't do more for the patient? Okay. Okay. Thank you. All right. All right. Okay. Brilliant. Thank you. I think that's clear.
Again, I wish to add something.
Sorry. Yeah.
Yeah. So regarding referring to referring to further for maybe to see an orthopedic consultant.
Yeah, your network is breaking. Not sure whether it's yours or mine.
Actually,
can you come back again, Mike?
Okay. Hear me now?
Yes, I can hear you now.
I said something more. Like you rightly mentioned, when you're making a referral, you shouldn't be very definitive what the outcome of the consultant would be. He's an expert. He can decide.
Yeah.
Maybe the patient not replacement or not, or now to make fit practice very easy. In some settings, there are pathways.
Yeah.
So if patient starting criteria, it just says to refer. So setting just makes it very easy to say if patient is this, consider his BMI, if what he has tried already meets the criteria, refer. So it makes it very easy if we can integrate that pathway where we work.
Okay. So Mike is
referral.
Yeah. Maybe we can do a different session. I think Mike, before you joined, we talked about proformas and templates, and I think we looked at general templates. But what Mike is highlighting is there are specific templates or pathways where you can practically follow. Certainly for MSK, less for neuro conditions, but for MSK, pathways in certain countries where it guides your decision. You don't have to worry about things. If this has happened, this is what you want to do. If this you've seen in the patient, this I want to do. And it's something that we can look out for next year or in the next 2 years to come. In terms of training that we can share with especially for those in the MSK bit, certainly there are lots of pathways or information. And any more questions? And thank you for the question as well as for the response. Okay, if there is no question, I think Chairman is here. I believe the Abdul Bagi or the NSP, any rep on NSP Gombe is here. Just to mention, your certificates will certainly be ready as soon as possible. Probably as soon as possible. And we will be issuing them at the end of today's meeting. thank you for attending. Okay, I think the chairman is here. Yes, you want to say something, or you just indicating your presence? Okay. Because your hands is up, so I thought you want indicating your presence. I suggest you already. Okay. So thank you all for coming. The final word is, remember, clinical documentation. If it is not documented, it did not happen. No matter how much brilliant or busy you are, if it's not documented, it's not happen. That is the only transaction that you have with the patient. And I wish you all the best with your practice. I would love to hear those stories. Like I said in my first training, we will be coming for a practical sessions next year in Gombe, around March, from the 23rd probably to 26th in March. It's around moving and handling, use of slide sheets that we looked at last time, use of possibly hoist. We will be coming with some of those equipments. There will be slide sheets, certainly. We'll be using some of those, probably return. We will be buying and coming with those equipment to use them. And watch out the space. There will be information sent out if you are interested. Because of practical, so we try to manage the numbers, but we will try our best to accommodate. Apart from those practicals, there will be a couple of trainings also on the theory parts that will be coming up, virtual training throughout the year. So watch out the space. If not, that will be the end. Have a lovely day. Thank you.
Thank you, sir.
Yeah, thank you for coming.
Thank you, sir. Thank you so much, sir.
Thank you. I'm gonna stop the recording.